I'm Margaret Reif, and I'm Jarvie's Executive Director. And on behalf of the Planning Committee and Jarvie's governing body, which is the Jarvie Commonweal Service Committee, I'm delighted to welcome you to our 19th annual colloquium. It's hard to believe that it's been 19 years. How many of you noticed the slides as you came in and got settled? We hope that the people that were shown on the slides remind you potentially of some of your clients or friends or family members. We wanted to portray images of older adults themselves as a way of setting the stage for this special day. It's a day when we ask you to set aside the concerns of your hectic work schedules and lives to focus on and reflect on the topic of hidden elders, serving those who are stigmatized, marginalized, or silenced. For those of you who don't know much about Jarvie, our founder, Mr. James N. Jarvie, such a unique name, you know, established the service in 1925 as his means of carrying out his charitable giving. He was known as the Coffee King in his obituary, importing coffee at the turn of the century. And his vision was to help people live, not merely exist, and serve older adults in the community. We still do this through our individual service program, which is our primary mission, and we provide direct social services and intensive geriatric care management to older individuals of the Protestant faith who live in the New York metro area. And many of those people receive financial assistance from Jarvie, as well as the services that we provide. We want to ensure that you all know that we are accepting referrals to the program. If you don't know much about the program and you'd like to learn, I don't know that either Joe Garner or Susan Cohn are in the room, but any of the staff at our table could direct you to someone that can help you get information. Jarvie also maintains an enduring commitment to one of Mr. Jarvie's core values, which is to help the common weal. And it's the greater good of all, and that's one of the ways we do that is through providing the annual colloquium. And we ask you to make the most of the day. We hope that it will provide you opportunities for growth, both professional and personal, to enhance your knowledge and skills, to network with colleagues, to receive CEU credits if you'd like them, and to be refreshed before you return to the unique and valuable roles that you play in helping to meet the needs of older adults. Thanks for your patience, and now, without any further delay, I'd like to quickly introduce the panelists for the opening session. There are bios in your program, and I'm not interested in telling you of everything that's in here. You all have the capacity to read, I hope. So just check out in there. And each person will speak in turn, followed by a discussion amongst the panelists that I have the privilege to moderate. And we will also hopefully have some time for questions from the audience. So this morning we have Donna Corrado, Commissioner of the New York City Department for the Aging, as our first speaker. We have Carl Dukes, who is a database manager and activist with the Fortune Society. We have Christina Curry. She's Executive Director for the Harlem Independent Living Center. And she will speak with the help of her interpreters who are here on the stage, Stephanie Fine, I hope I said that correctly, and Jason Farr. And last but not least, we have Dr. Rini Solomon, who will close the panel, and she's a retired associate professor from the Columbia School of Social Work and serves as a clinical consultant to a number of aging service organizations and maintains a private practice. Without further ado, Commissioner, I turn the podium over to you.
Well, good morning. This room is so wonderful, this whole venue. And this morning I took a walk and I saw the artwork and the beautiful environment that Jarvie brings. You know what? No, I'm going to embrace my short self today. Anyway. Thank you, Margaret, and thank you for the invitation to speak today at this colloquium. And I'd like to also thank the DIFTA staff that are here today and the Jarvie staff. I know just how hard they work all year long to put this colloquium together. And for years, first as a service provider and now as the commissioner, I still hear how wonderful this conference is and the high quality presenters, present company excluded, but that that speak every year, and people look forward to it. So I thank you for continuing in that effort, and I hope that you have a wonderful conference today. And it's also an honor to be on a panel with such distinguished speakers and some old friends. Despite being what many would define as a resource-rich environment, a significant number of the city's 1.4 million elders remain in the shadows, unseen and out of reach of the aging services as well as the supports provided by other systems. DFTA's traditional core services, including home-delivered meals, senior centers, NORCs, caregiver programs, case management, and home care. We reach over 150,000 seniors a year, but there are many that we do not connect with. The needs of these shadowed elders are quite unique compared with the larger pool of people that we serve every day. Often they are marginalized and sometimes stigmatized by the social welfare and public policies. With enormous changes taking place in local, state, and national health and social policies, I'm excited to be taking the helm of the nation's largest area agency on aging. And we are determined at the Department for the Aging to tackle the problems faced by these elders. I'd like to take the opportunity to highlight several of the most far-ranging policy developments underway because I believe that they have a significant impact in the lives of older New Yorkers, including those in the shadows. These policies include New York State's Medicaid redesign, the Federal Patient Protection and Affordable Care Act, and Mayor de Blasio's 5-borough, 10-year affordable housing plan to provide 200,000 units of affordable housing by the year 2024. Let me provide a few examples of how the policies can be fashioned to help address the needs of several of the marginalized groups that are the subject of today's colloquium. I will begin with homelessness and housing instability, problems that are becoming more prevalent among older adults, in part because of the growth of the population, but also as a result of the seemingly exponential rise in the cost of living in New York City. This is a particularly draining situation for those seniors with fixed incomes and those ineligible or unaware of benefits like SCREE, the Senior Citizen Rent Increase Exemption. For the first time ever, New York State is addressing the needs of the homeless and those whose housing is either substandard or unstable through the use of Medicaid dollars. State Medicaid funds are being invested in supportive housing and rental subsidies for older residents whose precarious housing situations represent a major health-related factor, including where housing instability leads to otherwise avoidable hospitalizations. And in the city, our mayor is tackling income inequality, if those of you don't know that, and access to affordable housing through the 10-year, 5-borough, 200,000 unit affordable housing plan. And a subsector, I'm happy to say, of the population being addressed in this plan is the population over the age of 60. Another major game changer is Medicaid redesign, which is significantly addressing a number of other factors related to the marginalization of elders. While the dual focused on cost savings and increasing quality, the state has continued on its path to incentivize community-based care over nursing home placement by moving from a fee-for-service model to a capitated rate structure. This shift is being actualized by the state's acceptance into the Federal Balancing Incentives Program, also known as BIP, whereby the state's New York Connects program will be adopted in all counties, including New York City, to streamline information about and access to high-quality long-term care services and supports. Of course, there is an important debate underway about whether, for example, the cost-saving aspect of these reforms is limiting people's access to much-needed home care, and serious analysis of such issues is critical as a way of making changes down the road to better match community-based services with consumer needs. Nevertheless, the focus on community-based programming has potential to be transformative over the coming years, particularly as it relates to the usage and reliance on aging services like home-delivered meals, social adult day, case management, and all of the other services that DFTA and many of you provide in the community. Redesign is also driving the care and services for individuals with mental health and substance abuse into a more holistic approach by absorbing these services into mainstream managed care. And as the culminating outcome of the state's success in Medicaid redesign, CMS, the Center for Medicaid Services, is allowing New York to reinvest over $6.2 billion to reform healthcare delivery and payment system in its newest initiative, DSRIP, which stands for the Delivery System Reform Incentive Payment Program. DFTA is particularly excited about DSRIP. Very excited. See, just so excited. Because the very nature of this initiative is to reach the previously unreachable. That is, those who have sometimes been overlooked due to the complexity of their care needs, or simply have not been able to have the tools to or the funding to address their needs. DSRIP will promote improved community-based response to older people's needs through encouraging collaboration among all service providers who touch that shadowed elder's life, from mental health clinics to aging services. In the weeks leading up to the submission of the DSRIP planning proposal, hospitals engaged social service agencies, federal health clinics, doctors, dentists, health plans, and home care providers to join them in addressing the needs of the marginalized, those who show up too frequently in crisis in emergency departments because they had an unmet need like housing. DSRIP is incentivizing these emerging PPSs, or performing provider systems, and they change these acronyms all the time, so it's hard to remember that. The important thing is that DSRIP, BIP, is bringing into New York State funding that did not exist before so that we can transform the service network to meet the needs of the marginalized. It is also important to note that these reforms in Medicaid in New York State are having a far greater impact on the population as a result of New York's ability to expand eligibility rules and draw down increased funds from the Affordable Care Act. However, while the Affordable Care Act itself opens doors for many, it is important to point out that according to the Kaiser Family Foundation, undocumented immigrants are ineligible for health care insurance in the state exchanges. As a result, roughly 500,000 of the city's 3 million immigrants do not have access to health insurance under the Affordable Care Act, leaving many to rely on emergency rooms, charitable care, and oftentimes no care at all. This is one issue that must be addressed given the city and nation's growing immigrant population. Not surprisingly, DFTA believes firmly that the Aging Services Network, with over 500 provider agencies funded to undertake 16 different programs, can be a key player in addressing the needs of the isolated and the marginalized by creating a more level playing field for older New Yorkers. For example, we at DFTA are actively engaged in conversations with several of these DSRIPs and PPOs and APOs and APPOs and all these other managed care entities, and we are part of a lot of these proposals that were submitted a week or two ago, with hospitals taking the lead, including the Health and Hospitals Corporation, that are seeking out fruitful partnerships with Medicaid managed care plans, seeking to identify and address the needs of older adults being released from prisons, for example, integrating health and behavioral health program into our existing services, and finding ways to better serve victims of elder abuse. DFTA is also exploring ways to increase its outreach to immigrant communities who have traditionally been isolated due to the lack of culturally relevant supports and services. and the high levels of poverty. Through our home-delivered and congregate meals programs, our traditional programs, we are making more and more information available in different language. And as we know, DIFTA continues to fund 2 population-specific innovative senior centers, Visions and SAGE, that address the needs of 2 distinct groups of elders who have traditionally been marginalized, the visually impaired and the LGBT older adult community. According to New York City Center on Economic Opportunity, 44% of New Yorkers age 60 and over live below or near the poverty level, yet only a portion of these seniors are enrolled in programs to help them access food, shelter, and medicine. Supports do exist to help them lead more economically stable lives, such as food stamps or SNAP, SCREE, HEAP, and it can go on and on. Great attention to benefits and entitlement outreach, counseling, and enrollment is needed to match these older people with benefits for which they are eligible. One major goal of DIFTA in the next 4 years is to work with other city agencies, other community-based agencies, to increase outreach to the needy and to help them gain these benefits. We're planning a full court press. This will include outreach and enrollment for some of the marginalized groups to be discussed by today's panelists, and I am eager to hear their thoughts and their ideas on these population groups and how better to reach and penetrate these shadowed individuals. I know that I in particular and all of us will learn a lot from their expertise and experience, and that we can then apply to our day-to-day work. Thank you.
He promised me he had a commanding voice, but I'm just helping a little.
Good morning. Can you hear me? Okay. My story or journey is one of a personal nature. I feel that this whole forum is about me because it describes me, marginalized, stigmatized, but not really silent, because at some point I regained my voice. After spending some 30-odd years in the upstate community, I was released to New York City again in 2008. I had just had cervical surgery on my neck. I had a brace on my neck, and my supervisor informed me that I had a place to stay. So when I reached that place, and they seen the brace on my neck, they started, shifting, hemming and hawing, you can't come in here. They didn't say that, but their body language and everything exemplified it. And I'm talking to this guy for about 20 minutes. And so I said, what's your name? He told me his name. I pulled out my papers. I said, that's your name? He said, yeah. I said, so why you bullshitting me? He said, well, I say, oh, man, come on. So he says, let me call my boss. So at that point, I began to gather my property. And I said, how far is the subway from here? Because I know it was a no-no. They were not going to be liable for me being there in the condition that I was in. I was not physically up to par, so to speak. I was 50 pounds under my normal weight because of the operation on my neck. And I'm still having problems with it. So he said, you have to go to Bethany Atlantic. Bethany Atlantic? It's a homeless shelter. And I proceeded there. I got there, and the place reeked of wine, beer, and other odors that I was unfamiliar with. So I started to go in. They said, no, you can't go in now. I said, why? I said, you got to wait till they open. Open? It was approximately 1:30, 2 o'clock in the afternoon. So I waited for about 4 hours in line. I get up every morning approximately 4 o'clock. So me coming back to New York City was no great deal. I'm getting up at 4 o'clock. So now I'm beginning to drag a little bit. I look down and see the strap on my bag is somewhat come loose. So I reached down to pick it up and almost lost consciousness. I said, don't let me go out here. 'Cause I said, if I go out here, I wake up, no shoes, no bag, no money, you know. So I get in line. So the lady says, I get to the one about 5:30, 6 o'clock. She says, you got a bed? I say, no. She said, well, you got to go to Bellevue. Bellevue? What's that? She said, no, you here. She gave me a piece of paper and told me to give it to the token booth clerk, and he would let me through. So I did. I got to Bellevue, and I had to wait and wait again. So I get to bed about maybe 1:30 in the morning. So I got to get up early because I have to report within 24 hours of my arrival. And so that was pressing. Now, I can't carry that bag all over New York City. So at that point, I begin to recreate. I go downstairs to the desk. I say, listen, they told me to leave that bag up in the locker. I don't think that's a good idea. She said, no, it's not. I said, all right. And so she went and got a supervisor. At that time, the supervisor come out, and the housekeeper comes in, and he says, where's the bag at? I told him where the bag was at. He says, okay, she'll get it. But you got to be back here by 4 o'clock, because 4 o'clock she leaves, and you have to wait till the next day. I said, good. So go over there, get a Metro card, and go. I got a Metro card, see my supervisor. I said, listen, this is the deal. Later on this evening, I'll be going to Ward's Island. I said, Ward's Island? I said, yeah. So she says, okay. So I leave there, and I said, well, I better get about taking care of my business. So I go get a food stamp card, apply for food stamps. By the time that's all finished, it's about 8:30, 9 o'clock. I know I got to be in Ward's Island by 10 in order to get a bed. So I get there, and it's another wait. I get to bed again about 1 o'clock. And I wake up the next morning. I figure, well, let me go pick up my bag. Before I pick up my bag, I better stop by Social Security and see what that's all about. Because all the stories I've heard about Social Security, welfare, you know, some of the stuff you got to weed out, because sometimes they embellish it in such a manner you think it's a gravy train, but it's nowhere near that. You know, you got to really struggle in terms of securing those funds, however they may come. So I get down there and I see a sign that says housing. That's upstairs. So I go upstairs to the next floor and fill out the application for senior citizen housing, because at that time I'm past 62, so I'm eligible, until I got to that part where it said, if you got a questionable background such as a criminal history, you may or may not. So I asked the lady after filling out, I say, what are my chances? She said, I don't know. I said, from your personal experience. She said, it's a hit and a miss. I say, all right. So I go back down, I get my bag, I go back to Ward's Island. That Sunday, I'm skipping a lot of stuff here. That Sunday, because I don't want to bore you. That Sunday, I go to Quaker service across the street at the Riverside Church, and I told them I was on Ward's Island. Ward's Island? You can't stay to Ward's Island. You got to stay with me. I said, no. We're gonna take this as it is, you know, and we'll work it out somehow. And so I was on Ward's Island from the 23rd of January to March the 10th. I leave Riverside Church. I go to the Fortune Academy at 140th Street and Riverside Drive. I knew a lot of people there, and so the guy said, okay, let me put you in touch with the special assistant to the CEO. I talked to him for a minute. He said, okay, come down to 23rd Street on Monday, and we'll see if we can get the process going. So I go down, we get the process going, and it still took a little time for me to get in. In the meantime, I'm still, you know, bagging, and the meals on Ward's Island are bad, to say the least, you know. And so after getting into the Fortune Society, the Academy, I was there for a couple of years, and then a miracle happen. I know you don't believe in miracles. They do happen. I got a Section 8, which was, and they weren't giving them out. They weren't giving them out to nobody. And I moved out of the academy into a brand new building next door, the Castle Gardens, 114 units. Half of them are for affordable housing, and the other half for people who have been somewhat incarcerated and fallen on hard times. But that whole process, I think, is one of an experience that I don't think I want anybody to go through. And I believe the answer to all of this is to be able to raise the level of social consciousness of the society. And I think that means that we'll have to start with the young, because this is not something that's going to happen overnight. Policies are good, but I think policies are based in what young people see and being able to initiate the things that take care of older people. I see more older people now picking out of the garbage than I seen 35 years ago. And it's after a while, you can't ever get used to seeing that, Was that somebody's mother, somebody's father, brother, whatever, And there has to be a better way. There has to be a better way. Donna said they serve 150,000 people, and there are much more in the shadows. And there's much more to this story. But at this point, I think my time is up. Thank you.
Christina.
Hello, everyone. Good morning. Good morning. How are you today? Okay. Hello. Are you awake? Thank you. All right. Come on. Pretend like you're here. You're woken up. All right. All right. Can you hear the interpreter well? Okay. Good. All right. I'm going to start. My name is Christina Curry. I'm the executive director of the Harlem Independent Living Center, and I have the attitude of Harlem. All right? So I'm going to start with myself. I became deaf. I was not born deaf. My vision has been reduced, and that's recent. I was not born blind. I can't walk. I have a list of ailments, a very, very long list. I'm a woman. I'm a recent member of the AARP. Booyah. Okay. I think I qualify for each federal quota group that they have. Okay. I'm also, every day I face challenges because of what I said before, everything I'd said.
I'm going to voice for myself now. But remember, I said I became deaf. If you can't understand me, pretend, okay? One of the things I know or I've experienced as I become older and more disabled, many social service agencies hire what appears to me very, very young kids. When did that happen, okay? They're all young. They don't know how to, I'll say, talk to us. That when you come into the front desk, they're rude. Yeah, I can't hear, but they mumble. They look down when they're talking to us. They don't respect us. They'll say, here, sign that. Well, even if you don't know that I can't see, I can't see. Don't shove the paper at me and say, read that, sign that. Show me where it is. Tell me where it is. Take the time to explain things without the attitude. Because remember I said, I'm from Harlem. I also live in the South Bronx. I can throw back attitude. I'm old school. So you give it, I give it back, and I can do it 3 times better. So then it becomes confrontational. I don't need that. If we're going to an agency for service, I don't need the added stress of how do I deal with the front desk? And will that translate to the next person I have to talk to? Will that front desk person say, she's rude, so then I experience rudeness throughout my appointments? We don't need that. When I go in and I have had people say, here, hun, sign that. I'm not your hun. How do I help you, dearie? No, that's not my name. My mother didn't name me that. I would like to be asked, what would you prefer to be called, Christina or Miss Curry? Don't just say, Chris, come on over and say, no. You're 25. I'm how old? Pretend that you understand how to deal with the generation I come from. I was taught respect, and that's a big deal. If you don't have the respect when you first come in, you're already feeling like, I don't want to be here. I don't want to do this. And I have to, and you're making me feel small. I don't like to feel small. I'm over 5'8". I don't want to feel small. It's give me what I give back. If I come in hostile, yeah, be hostile. But if I'm not, if you're having a bad day, that's not my problem. You're at work. Pretend you like where you are. Yeah, come on, try. One of the things that I will do, and again, I'm talking in general about social service agencies, when I have to go to a doctor's appointment or so forth, and the young girl in front is really just having a bad day. May I speak to your supervisor? That works only if the supervisor is from that same generation, because if the supervisor is 10 days older than the person at the front desk, they don't know what I'm talking about. Okay, let me speak to your director. They seem to get younger and younger as you ask for the higher titles. Like, I have to explain life to you too. I got to show you how to do this. I believe it's attitudinal barriers, the need to change attitudes. That even though we have policies implemented, if at the top they don't get it, it's never going to filter down to the people that are in the front line. If many of our young or our youth never expect to become a senior themselves, they don't know what to do when we come in. If many of those who are youth, or I'll say youth now up to those 30 so, if they have no one in their family that's over 50, they don't get it. I know people, I've worked with people that don't understand that one day I can walk and the next day my knees just give out. I can't move. They don't get it. They don't understand that I don't like the jokes of, oh, you're old, it's okay. Yeah, I forget things. Sometimes I'll joke, but sometimes not. And when I'm at the doctor's office, when I have to go to any of those other agencies, I don't want to hear about, oh, you just sit there, it's okay. Don't talk to me like my IQ has dropped by 20 points because I can't walk anymore. I don't see so well. I don't hear so well. Blah, 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 blah. My IQ has nothing to do with what's going on with me as an individual with my body. So, as I like to tell some of them, don't get it twisted. Just because I can't move as fast doesn't mean I don't understand how you're treating me. It's about learning to train those who are coming up behind us so that they can work with us. And one of the reasons why I can be so adamant about what needs to be done now, and when I go to agencies, I will throw my title in. I will tell them what I do. Why? Because when I retire, unless I move and leave New York, I'm going to need these same services, these same people. So I really want them trained now before I'm retired and I don't have the weight of my title or my agency. And it's unfortunate that I or others would have to do that, but we need to, because those who are coming up behind us are not properly trained, and they need to know. Why? Because hopefully one day they too will be a senior. They will reach the age of 50 or over. They will become an AARP member. So we want them to understand now how to work with us, not to ignore us. I don't know if I have enough time left, so I'm just going to wrap it up and say, I really thank you for listening to what I have to say. Right now, I'm also rushing because my knees hurt and, got to focus on that for the moment. But I thank you all for your time. Thank you.
It's so good to be here. Hello, hello. Good morning. I feel so tall. Oh, my God. There's a Yiddish word for how I feel right now, and it's called chutzpah. Translation: who are you to think you have the answers? Mr. Dukes and Ms. Curry have told us how it is, what it's like to experience stigmatization and marginalization as an ongoing aspect of life and of their fight to overcome. Commissioner Corrado, who did look younger, not better, but just a little younger a little while ago when she was merely director of neighborhood services at Catholic Charities, has described DFDA's efforts to initiate services that hopefully will substantially improve the lives of hidden elders, whose resilience can be sustained only by the provision of these essential services. And I've been asked to speak about how we in the social service and healthcare fields can work with clients in ways which enhance their power, in ways which search out people's strengths so that in the face of and despite being marginalized, they can overcome, as have Mr. Dukes and Ms. Curry. It's a tall order, and I don't have such prescriptions. I do want to share with you, though, my struggles through the years as a practitioner and educator to work with elderly clients in ways which help them recognize that they do indeed have the capacity to reject society's negative definitions. Some major principles have guided my work. 1, to work well with anyone, we must first be curious about who is this particular person. Wonder how he or she has managed to achieve age 75 or 85 or 90. 2, we need to search out people's strengths while recognizing the problems, and then find at least one aspect of that person with whom we can empathize. 3, formulation of the work to be done must be developed mutually, with the what and the how of the work articulated clearly and agreed upon by all. I guess that's my mantra for developing a mutually respectful relationship. We're speaking today of stigma and marginalization of people society has defined as the other, not us, but them. Yet each of us has been the other at some point in our lives. Take a minute, please, right now. Think about, remember that time in your own life when you were stigmatized. So just go inside for a minute, half a minute. Think of that time of your stigmatization. I ask you to do this because our own experience of stigmatization can provide the basis for empathy with our clients. Too often, we forget that at one time or another, each of us has experienced some of what our clients struggle with. And stigma has a host of psychological concomitants: shame, guilt, anger, rage, despair, and a range of social, economic, biological consequences, such as difficulty, sometimes inability, to access employment, housing, social networks, education, recreation, healthcare, to name just a few. A concept which has influenced my work is that of blaming the victim. It's a phrase coined by the psychologist William Ryan to describe the ideology of justifying racism and social injustice against African Americans. It was then adopted into the discourse on sexual assault, especially as regards women who are raped. Today, it's used in relation to poor people, people with mental illness. In fact, all people whom society stigmatizes are, for the most part, blamed for being who they are or being in their current situation. Sadly, victim blaming presents itself in the healthcare system, and that's what I'd like to focus on now. When patients are personally held responsible for requiring medical care or for falling ill, and other factors outside of their control are ignored, such as social, economic, cultural factors, I view that as victim blaming. It often results in misdiagnosis and poor quality of care. Sue Estroff, writing on chronicity, notes that disabled persons most often have material and social needs which exceed their resources. And at the same time, there's an American cultural ideal that adults should have and produce more resources than they need or are provided by society. And those groups which fall short of this ideal are stigmatized, are seen as inferior citizens. Poor people, cognitively, physically, emotionally impaired people are in this category. And mental illness is particularly misunderstood. They could snap out of it if they tried, is an attitude which persists even today. Depression, like PTSD, is not seen as an illness, it's seen simply as a personal weakness. Obese elders, alcoholic elders, are also often seen as only that, obese or alcoholic, while other symptoms for which they seek help are ignored. The effects of victim blaming are serious indeed. Estroff's discussion of the language used by us is particularly incisive, I think. She finds that some chronic illnesses, like cancer, multiple sclerosis, arthritis, fall into a to have category. We say, she has cancer, or I have arthritis. Other chronic conditions, however, fall into what she terms the to be category. These include alcoholism, dementia, drug addiction, amongst others. The possessive verb is used here. She is demented. He is addicted. She is mentally ill. By saying she is mentally ill rather than she has a mental illness, we see only a mentally ill person. She's borderline makes her only that. In contrast, she has cancer differentiates the illness from the person, enabling us to see more of the whole person. And more, the physical symptoms of mentally ill people are often overlooked, since all symptoms become attributed to their psychiatric diagnosis. Estroff terms this phenomenon diagnostic overshadowing. I suggest we might examine more deeply our use of jargon, our language. Just a little more about the implications of language as a social force. Hannah Zelig speaks of dementia as a cultural metaphor. Just the word dementia evokes profound dread. It has replaced cancer as the scourge of our day. Descartes wrote, "I think, therefore I am." And who am I when I can no longer think? Dementia is variously described as an epidemic, a crisis, a plague, and a huge economic burden. We speak of the rising tide of dementia, of the tsunami of dementia. But how similar is this to how AIDS was described in the 1980s? And why are we not mounting the barricades today as AIDS activists did in the 1980s to demand greater research and treatment efforts, greater financial investments in these efforts, in services for families and caregivers and people with dementia. Discussion of Alzheimer's and other dementias leaves people feeling terrified and powerless. For dementia evokes a combination of anxieties about old age and cognitive decline. To be old, cognitively impaired, mentally ill is to be triply marginalized. I suggest that in addition to activism, as practitioners, our task is to recognize the continued personhood of a client, a parent, a friend with dementia, to search out what defines humanity for these people. And further, I say that what defines society's humanity is how we react to and value the caregivers and the person with dementia. In his poem, Mother of the Muses, Tony Harrison reflects on the nature of identity and its relationship to memory. He questions, if we are what we remember, what are they who don't have memories as we have ours? Harrison's also concerned with the relevance of historical memory and cites the collective memory loss of Hiroshima, the Holocaust, Dresden, Schwerner, Cheney, and Goodman. To some extent, perhaps we all forget in order to carry on. I'm going to skip the whole next piece because I see I don't have much more time. I'd like to present two practice approaches which I believe are effective in work with stigmatized and marginalized people. The first on the use of self-compassion, and the second on the use of group services. The concept of self-compassion is very close to my heart, for as a Gestalt therapist, it serves as the foundation of my practice with people of all ages. Imagine my delight when I came upon the article in the Gerontologist, which you all have in your folders, called Self-Compassionate Responses to Aging. Self-compassion involves treating oneself compassionately, with caring, concern, and kindness when problems arise in life. Compassion is something we have for others, but often neglect to have for ourselves. It involves being aware of one's own suffering without minimizing or exaggerating it, being non-judgmental about our own inadequacies and failures, recognizing that our experience is part of the human experience. Compassion is neither self-pity nor letting yourself off the hook. The behaviors which accompany self-compassion are behaviors which we can learn and can teach to our clients. They include, 1, becoming aware of how we assault ourselves emotionally. 2, how to treat ourselves kindly. 3, how not to engage in undue self-criticism or self-pity. 4, how to resist personalizing difficulties and engaging in self-blame. 5, how to broaden our perceptions of reality and maintain as objective as possible a perspective on the situation of distress. Irving Goffman and others have written that people who are stigmatized incorporate much, if not all, of society's negative view of them, unless people affiliate with a supportive network that includes social and political components. A self-compassionate approach will support such affiliation. Earlier studies with young adults showed a high correlation between self-compassion and indicators of mental health, such as lower depression, lower anxiety, and higher life satisfaction. Current studies find this holds true for older adults as well. Researchers found that although all older study participants experienced negative events, they thought about them differently. Participants who ranked high on self-compassion were found to have a more positive attitude towards their experience. Of particular interest to me was their attention to the difference between self-esteem and self-compassion. At a conceptual level, negative events threaten self-esteem by challenging our sense of acceptance. Gilbert and Irons found that in the face of negative events, self-compassion deactivates this threat system, since it leads people to engage in thoughts and feelings which are characterized by self-worth. For example, rather than thinking, how could I not have known that, I'm so stupid, to think instead, wonder why I missed that? Well, maybe I don't have to know everything, and I don't have to beat myself up for it. Self-compassionate thoughts, those characterized by kindness, common humanity, and mindfulness, may be particularly important for maintaining well-being in old age, and even more so in dealing with stigmatization. What is so compelling is that self-compassion can be learned. To help people identify their self-critical voice and to stop shooting on themselves is the first step in the process. Identifying and practicing self-compassionate responses is the work which will effect change. And I'm not suggesting that this is the easy or the only way, but I do know it's worth the effort for ourselves and for our clients. Let me end with a discussion of the potential which group participation has to reduce the powerlessness which affects vulnerable people and perhaps all of us. Group practice is empowerment practice. Stigma serves a social function, and the primary function is that of social control, keeping the others in their place, silencing them. Stigma institutionalizes the blockage of access to needed resources and thereby institutionalizes poverty and vulnerability. Not only do the more powerful groups prevent or hinder marginalized people from acquiring essential opportunities and resources, they, in addition, abuse their power and inflict harm directly on those with less power. Helping clients acquire greater control over their lives can be accomplished to a limited degree only when working on an individual basis, even when using a self-compassionate approach. Social forces are much too oppressive, too invested in maintaining the status quo to relinquish power to individuals, particularly socially isolated individuals. To become empowered to use one's power requires the support and protection of a group. By helping group members to view their problems as related to such social forces as ageism, classism, racism, sexism, rather than as individual deficits, group members' problems are universalized and stigma and isolation are reduced. Mutual support is a critical, empowering professional task. It requires inviting members to build on each other's contributions and encourages collective action. As members learn to develop and reinforce mutual support, they begin to trust each other and become more comfortable to share personal and taboo concerns. This process enables people to experience their needs and problems as not being unique or deviant. Because they have had similar life experiences, group members are in a special position to provide understanding and acceptance. And when a member resists dealing with his or her problems, other group members are also in the special position to challenge their attitudes. Finally, groups can serve as critical forces for people to act and gain greater influence in society. Collective action has greater visibility and public attention. Collective action diminishes individual isolation and risks of reprisals. Most important, it increases chances for success. To retreat from one's environment inevitably leads to a sense of powerlessness and incompetence. In contrast, to actively engage in group action and to influence social forces leads to a greater sense of power and competence. Audre Lorde was so right when she wrote, "When spider webs unite, they can halt a lion." And from Maya Angelou, who will always be with us, she wrote, "I thought if I wrote a book, I would have to examine the quality in the human spirit that continues to rise despite the slings and arrows of outrageous fortune. Rise out of physical pain and the psychological cruelties. Rise from being victims of rape and abuse and abandonment to the determination to be no victim of any kind. Rise and be prepared to move on and ever on." Thank you.
There was a lot in your presentations, and I want to ask, Christina, are you happier staying there or coming back up on the dais? Okay. She's going to come back up. So another moment of transition. And shadowed individuals. What a way of framing the discussion for today. And I found myself sitting there thinking, oh, why didn't I think of that? And then I tried self-compassion, which is, that's why you invite other people to come and present. They bring great ideas. And you don't have to know everything. I found myself hearing and thinking about things on multiple levels. And that's actually what we hoped that this session would do, would think about the policy and bigger picture, and then also to think about more the work that is done with individuals and ourselves as well. So I came up with some questions, but I am curious, before I ask questions, if you have questions of each other, the four of you. Anybody have one? And if you do, on your table there's a microphone and you need to turn it on. You need to pull the switch on the top up towards you. Okay, so one of the questions that I have is that I heard that we need to look at how we could raise a level of social consciousness and how we could address attitudinal barriers. And I wondered if there are particular things that you would say, either Carl or Christina, that would be on that list of actions that people could do to actually attack those problems. Turn it on. No, I turned it off.
Oh,
Sorry.
You sneak. It's on. It's on. I think when I think of social consciousness and how that is built, I think that should take place with young children being surrounded or have some point in their lives with older people other than their grandmothers or grandfathers. Because they're drawn at that point to those people because they know them. And I think to build with that has to go on for a certain period of time. I think that they have to be immersed in it in order to begin to look at how policies affect the lives of people. You know, people sit and they make policies without even consciously thinking about how the effect of these policies are going to take place. You know, with all good intentions, but there need to be a deeper seed in terms of viewing it. And I think it comes from, I look at it as a sort of a groundswell to build that. This is something that's not going to happen overnight when you start talking about raising the level of social consciousness, that it has to be ingrained, because people have to look at another person and be able to see themselves. Because if not, then this whole process continually go on the way it is. and we'll never solve it.
Thank you. Christina, do you have thoughts about how there are particular actions that could be taken around addressing those attitudinal barriers that you spoke about?
We have experience collectively. We can't ignore those who are coming behind us. So it's incumbent upon us to reach out to the younger groups and share our experiences, talk to them. Don't do like the generation before where it was speak when you're spoken to, otherwise sit in the room and be quiet. We need to reach out to the generations that are coming up and share our experiences, because as Carl said, if they understand us, then they can see themselves in us. And if they see, oh, it's not so difficult to communicate with this person. And yeah, they may be different in how they move, but so am I in other ways. So why not share our experiences? Because that's how we continue on anyway. When we're no longer here, someone else will remember what we've taught them. So it's a two-way street. We have to give in order to get as well.
That's very helpful. And what I find myself thinking about is, where are those programs in the community that are actually doing this right now? Because I know that they exist. There are programs where there's very intentional work being done to bring young people and older people together, and to have it be that there's that opportunity to truly see and learn from each other. They're not as plentiful as I'd like. Commissioner, do you think that that's something that DFTA could look at or think about in terms of programming? Turn it on.
Okay. I think there's never enough intergenerational programming, but I'm going to get back to basics, because what we're speaking of are manners, respect, and dignity, and that's a social work value, and it's a social justice value. And I really feel like we always get back to this, right? We go back to our programs, we go back to our agencies, and I think we've lost the sense of supervision, which is so critical to running a good agency. Supervisors, and hopefully they are a little older, should be reinforcing these social work values. And social work values, human values, call them whatever you need to. They're basic human values and dignity and respect and worth for themselves, for others, and we need to impart that. And there's many ways we can do that. But if it's constantly reinforced in the agency by the older workers, by the supervisors, by the director, and they lead by example, I think that we can combat that problem. And I also would have conversations with the deans of social work schools and the deans of every school, because this is an issue, and we've brought it to, I know at DFTA and in certain areas when I've had the opportunity to bring it to their attention, because in my old world as in hiring young workers, I found that many of the same problems existed, and they needed to know that they had an opportunity when they were forming these minds and workers while they were still in school. They had an opportunity to address these issues. So I don't think it's something that cannot be solved. I think that if we make a concerted effort to lead by example, to reinforce, to get the message out that it's not acceptable. It's not acceptable on a human level not to treat each other with respect. And that is, something that really, it bothers me that social workers in particular come out of school with and I know it's all the millennials and all of that stuff, and that it's a mindset that, they come in and it's true, and I hate to generalize, but this has been was my experience when I was executive director at Catholic Charities, is that, they would show up for work and day one, a recent graduate, and they wanted to be executive director the next day. It takes a couple of weeks, but
At least.
and really, I don't know, we have to change that mindset, and I think that the way we can do that is through stronger supervision, getting the message out to the schools and the teachers and the professors. They can work on it before they even get to that point, and there's opportunities in internships. We all have interns in our programs, and lead by example. Thank you.
Thank you. It makes me think about, Rini, you're pausing and asking all of us to sit and think about the moments when we have been ourselves stigmatized or marginalized. And everyone has had that experience in some way in their life. Some of us might judge whether someone else's experience was valid, but that's getting into a problematic area. I think that it's one of the places that we rarely go. We don't necessarily stop and think when you're going in to see someone, or someone comes to you who has attitude, is a royal pain, and is just gonna, eat up your time. We don't stop to think, okay, what is the way in which this person has probably experienced not being seen, not being heard? They make a lot of noise for a reason, because nobody's listened unless they have screamed. Nobody's listened unless they have yelled. And how is it that it's possible to say, I want to start today by saying to you, I really want to hear where you're coming from, and we're going to get a lot further if we can treat each other respectfully. There's all kinds of ways that I imagine that what you're talking about is just some of the core values that really do stem from, we also really have to treat ourselves kindly. And if we take that as a higher level of order in guiding us, it makes a real difference. Do you want to say something in response to that, Rini? Do you have thoughts about it?
You said it beautifully.
Okay. Wait a second. I'm not ready. I'm not done with letting them talk to each other. Anybody have a thought that's come up as you've been hearing each other speak a little bit? I want to take on bigger picture issues, which is that, Donna, you talked about how this Medicaid redesign is something that there are questions about in terms of, are the cost savings that are the focus of this really limiting access to services for the individual? And that there's going to be need for feedback about that. One of the questions I have is, how is it that the people in this room could constructively help provide some of that feedback for the assessment of, is this effective? And where might those opportunities lie?
We have an old saying in social services: if you have 3 services to offer, right, everyone that walks through your door needs those 3 services, right? So in this whole MRT world of managed care instead of fee-for-service, for many years there was a lot of self-dealing. So that became the framework in a fee-for-service model. And I'm not, speaking as a crusader for managed care, not at all. But there was some incentivizing around certain disincentives that can now happen if somebody is overserved, right? So we have to constantly be mindful now in this new world of balancing what it is the person truly needs to be safe in the community, and what they don't necessarily need. And there are limited resources, okay? So if somebody needs 12 hours of home care, they should be getting 12 hours of home care and not 24 hours of home care. Therefore, 12 hours can be spent on someone else, right? So everything, but we have to be very conscious of what it is that we're advocating for. Mm-hmm. And we have to make sure that if somebody needs 12 hours of home care, as one example, that 2 hours is not acceptable. And what do we do to make sure that those needs are being met? And that's, a very fine balance. But we all do understand, the whole reason for this is that healthcare costs naturally were out of control. And we want more people to access services, and it's okay to have more people on Medicaid if that's what we need to do, and on Medicare, and bring in those resources, because there are more people getting older, and we need to be able to serve them, and we need to broaden the pot of money that traditionally we've had over the years to serve this population. So it opens up a wonderful opportunity for us to bring in federal dollars into the state, into the city, so that we can serve more people, but we have to be very judicious in the way that we do that.
Agreed. We have 2 members of staff or volunteers that have microphones that they can walk around with. So we can take a couple of questions from the audience. And I would ask that they be questions rather than comments, if you can bring yourself to do that. This is true. Please wait until they give you a microphone before you start asking. So I know there have to be questions. Here, Paul, towards the front.
Did you hear me? Yes. Okay, I'm going to try to formulate this into a question, but it's not a question. My name is Miki Navarro. I'm a social worker and a director of a center at the Red Oak, sponsored by DIFTA and Westside Federation. I just want to add to the services that we bring regarding training the young. I have a pilot program beginning this summer in July, 8 weeks. Grandparents who are babysitting for grandchildren during the summer, they will enter into our program. We have a special program designed for them. There will be a lot of exposure, and now I will add some of what your issues are during this exposure. We're talking about civilities, we're talking about socialization and getting to know older adults other than the ones they live with. And so this is, I'm sure that Donna knows about this, but she has so much, so I just wanted to add to how we're helping with this process also. And you could put that into a question.
Other questions? Besides, are you saying you have a question? No, okay. Back there?
Hi, Judy Zanglo, Executive Director of Sunnyside Community Services. Most people I know say they never want to be an Executive Director, Donna. So, and some days I say I agree with them. My question is, when I think this requires, I characterize it as customer service, and I think it requires not only effective supervision, but training. And the pushback I get, and this is addressing a system change, is that there's so much pressure to meet the units or meet the contractual requirements. I feel very emotional about this. That people don't feel that they frankly have the time. And I think that if some of that pressure could be relieved in whatever way that can be done, I think it would be very helpful towards this goal.
Thank you, Judy. Other questions? I'll even allow a few comments.
But I can comment on that one. Duly noted, Judy, you know that, and we've had this discussion before, and you're preaching to the converted, and as the opportunities come up at DIFTA, I know, and we are starting to challenge every bureaucratic barrier that exists. And the only way for me to know which ones are is just in conversation with my staff. Why is this? Why is that? We're challenging everything. So if there is a way that we can make life easier for our voluntary agencies, that essentially they're carrying out the work that DIFTA's needs to do, and that's our mission to do. So we basically have handed that job over to the 250 provider agencies. So we need to make your lives easier. And as a former director of a program sitting on the other side, I understand that totally. So we are constantly, when the opportunity arises in our everyday conversations, challenging every rule and regulation, if it exists. Is it a SOFA regulation? Is it a DFTA regulation? Is it a stupid regulation? Does it make sense? Can we get rid of this? There's all of those conversations are happening.
Thank you. I see a question over there and then over here. Well, you can start here.
Hi, it's Steve Gould from Visiting Neighbors. There's one area of, one group of hidden elders that has not been discussed, and that's the hidden elders that are the oldest of the old, that are not qualified to go on Medicaid, nor are not well enough financially to have private pay. And Donna had brought up the fact that if there are issues with this managed care system where somebody is going back in, let's say, to the hospital after they just came out, there'll be repercussions to the hospital. There's nothing being done for those seniors to be able to get to the doctor. At least with our group, we used to have intergenerational students that would get the opportunity of being with elders, and also able to take the elders to their doctor or shopping. And this is a whole area with a large segment of the elderly population that is not being dealt with. And I'd like to know what the panel thinks can be done about that.
Can I answer that?
Sure.
Well, there are programs being designed specifically to address the issue of hospital discharge and care transitions into the community. And one component of those programs, which hopefully will be proliferated because they do keep people out of hospitals and prevent to some extent their re-entry into the hospital within a certain period of time. And we're finding that once that period ends and that intervention ends, that they may go back into the hospital. So we may want to look at models that extend the period after hospital discharge in terms of care transition planning. And one of those things is following up with medical appointments, making sure that those arrangements are being made for doctor's appointments, that the senior understands their instructions for their medication, et cetera, et cetera. And I think that's a very important, an important program, not just to save hospitals money, but no one wants to go into a hospital, and nobody wants to be readmitted into a hospital because they have a secondary infection or they can't take their medication. And then people should stay out of hospitals at all costs. So those programs, we need to collect the data to make sure that they're working, and what's not working needs to be tweaked, and it is part of the overall managed care redesign.
One question I have about that is, if you don't qualify for Medicaid, right, and you have some money, but you don't have enough money to pay for services, why isn't that service something that's coming through Medicare? Is there any movement afoot to look at how Medicare could actually help to provide some of that care transition support? Do you know?
Well, I think it's being discussed because it's all Medicare, and actually there's someone on the panel that may be better able to address that. Not on this panel, but Valerie may be able to handle that question in a more intelligent way.
Paul, Valerie's right over there.
I can't see that.
So the Medicare issue is what I'm asking about.
Right. I certainly can't speak for Medicare, but it's really Congress that designed the Medicare system, and there was Medicare healthcare coverage that was proposed and actually enacted about 14 years ago in 88.
Yeah.
And then it was repealed with a huge lobby effort because it did, the way it was funded was to tax the elderly. And so ARP went ballistic and got it repealed. So that, it's political. And so if anything, the Medicare healthcare benefit is, as you said, very, very limited. It's only for skilled needs. It's not for the sort of services that are being raised that are so crucial to help people in their daily life. So we have ISAP program, but there's a long waiting list for that, and it's very limited. But that's about the only thing, and there's a huge gap.
Activism, that's the other part of what we need to do. And I heard Rini say that, but over here we have a question.
I'm Jed Levine from the Alzheimer's Association, and I want to thank the panel for a very, very thoughtful and inspiring morning, and I especially want to thank Dr. Solomon for bringing up the issues of dementia and Alzheimer's as highly stigmatized and almost invisible, even though it's an enormous problem. It's not something that we're hearing about. So my question is, and I hear this from elected officials that we talk to, who say that nobody at our town halls is saying, what are you doing about Alzheimer's? They're asking about housing and education and jobs and all of those other major social issues, but we need to raise the voice. So my question is, what is the role of political activism and social activism in raising the awareness and the consciousness so that there can be more funding and more services?
Rini, you want to?
I think the piece of my presentation that I like the best is when I came upon the parallel with the HIV/AIDS activism and dementia today. I do truly believe that we have to man the barricades, that political action is essential to getting the funds we need for dementia, and to involve not just the professionals, but families all over the country are waiting for us to lead the way. I don't think we can rely only on families to do this. We have to be very much part of it. And congressmen really respond to that kind of pressure. We know that. They don't respond to other kinds of pressure. And the Koch brothers may not even respond to this. But I think, I know that we have had success in doing this before, and we can do it again.
I have to ask a question. What time is it? Well, that means that we have to be done with this part of our program. And I'm apologizing to those of you who have questions that you didn't get answered. There's all kinds of time to do that. The elevators are in the center of the building. The blue sheets of paper tell you where to go for the different workshops. Thank you for your time and attention. See you at lunch.